Thank you very much, Nadi. I wish I didn't have to interrupt that lovely conversation going, which could have perhaps go longer to address all the questions and queries from the participants. So I'm afraid I will take a different angle here, more focus on modifiable risk factors and prevention. I am a psychologist with a background in clinical neuroscience and epidemiology. So pretty much my experience to date is on epidemiological observational studies. Do you see my slides?
Yeah. Yes, we can.
So thanks again for the introduction. It's great to be here and to join this fantastic conference on dementia research. I have nothing to disclose. So one of the area of my research interest is related to modifiable risk factors associated with cognitive epidemiology, cognitive decline, and dementia. So the disappointing results of pharmacological trials highlight the need to prioritize more dementia prevention, which has been highlighted as a key priority in managing the dementia epidemic. So in the next minutes, I'll present some of the evidence on the dementia risk factor from epidemiological studies. A very brief classification has grouped the various risk factors in non-modifiable, such as age, gender, ethnicity, genetic factors, ApoE, the main candidate. Modifiable, those factors over which we have a bit more control, obesity, poor diets, physical inactivity, and smoking. And those considered treatable, such as hypertension, prediabetes, and stroke. Alzheimer's disease arises from a complex interaction between genetic and environmental risk factors, with genetic variants being under the influence of individual responses to environment. Neuropathologically, as we heard yesterday, Alzheimer's disease is characterized by hippocampal and cortical neuronal loss, amyloid beta, and accumulation of tau in intracellular neurofibrillary tangles. And this could accumulate in time with almost 1 or 2 decades before the first behavioral and cognitive symptoms could actually manifest. So that's why it's important to understand more what can be done to prevent dementia in the first place. From the many candidates that have been put forward, as you can see here in the top right diagram, for some, there is a stronger evidence, as you can see depicted with the blue arrows for risk factors such as traumatic brain injury, midlife obesity, midlife hypertension, current smoking, and diabetes. And in terms of protection, as depicted in the green band, years of formal education seems to be protective and increased physical activity. There is moderate evidence depicted with red arrows for Mediterranean type of diet, rich in fruit and vegetables, and cognitive training. Somehow lower evidence is for the history of depression in relation to a risk of dementia, sleep disturbance, and the jury is out for moderate alcohol consumption or social engagement and high cholesterol or triglycerides. Next, I'm going to present some of my work in relation to modifiable risk factors and dementia. So I will start perhaps with obesity. And in a representative sample of English older adults named the English Longitudinal Study of Aging, in short called ELSA, a study you also heard yesterday from Irasema, 74% of the participants who developed dementia over the study period, which was follow-up for 12 to 15 years, we found out there was an increase of dementia incidence in those who were obese and had a large waist circumference. We also found some gender differences, and the association were stronger for women than for men. So women who had central obesity had about 39% greater risk of dementia compared to those without central obesity. This work has been published in International Journal of Epidemiology. Moreover, we took a step back and asked if perhaps poor nutrition or, let's say, low fruit intake of vegetable could represent one of the causes for obesity, but also had a direct link with dementia. So we recruited 6,000 participants with genetics data and studied several interactions between polygenic scores created for Alzheimer's disease, for schizophrenia, and for general cognition with daily fruit and vegetable intake. And we analyzed this interaction in relation to 10-year follow-up in ELSA for dementia incidence. So what we found is that consuming fewer than 5 portions of fruit and vegetables per day was actually associated with 30% greater risk of dementia, especially in those with a higher polygenic propensity. And in terms of the polygenic score, we found that 1 standard deviation increase was associated with 24 higher risk of dementia and 39% of increase for Alzheimer's disease diagnosis, especially in participants who consume fewer than 5 portions of fruit and vegetable per day. So this work highlights that a diet low in fruit and vegetable is important influencing factor for dementia in the context of polygenic predisposition. And this work has been published last month in BMC Psychiatry. So considering the additive role of these factors, we was also interested in investigating the role of co-occurring lifestyle behaviors, because as we know, they all seem to be related one way or another. And furthermore, we are also interested in the mechanism through which perhaps poor lifestyle behavior will influence dementia risk. So the hypothesis was that poor lifestyle behavior might influence systemic inflammation in the body, and that level of systemic inflammation might further influence the risk of dementia. So in order to do that, we created an index of lifestyle behavior, which was combining with a score of 1 for poor lifestyle behavior with alcohol intake, poor fruit and vegetable consumption, smoking, low physical activity, sleep duration, social engagement, and cognitive activity. So we derive a total score ranging from 0 to 7, where the higher score, they were indicating a higher number of health risk behavior. So we also monitored these people for 10, 12 years follow-up, and we found out that subsequent dementia 10 years later was increased with 1.21 for each additional health risk behavior. However, we found that systemic inflammation did not mediate the relationship between lifestyle factors and subsequent dementia. So perhaps there are other mechanisms we should look and investigate. Associated with poor lifestyle behavior are socioeconomic inequalities, which are also a strong determinant of subsequent health, and including dementia and mortality risk. So in a separate study, we investigate the inequalities and found that incidence of dementia was socioeconomically patterned primarily by the level of wealth. And this was calculated by summing up the wealth coming up from values of property, possession, housing, artwork, jewelry, and also including debt. So we wanted to investigate also if the change in perhaps inequalities differ across decades. In order to do that, we derive 2 different cohorts. So we basically split all participants of ELSA in 2 groups. Those born earlier between 1902 and 1925 as age cohort 1, you see in the left, and age cohort 2, those who were born between 1926 and 1945. And we create this derivation by using a median split of all birth years. Now I would like to ask you in the audience if you think the gap between rich and poor have increased over the years or not. So please raise your hand if you believe that socioeconomic inequalities have increased over time. Yeah, so a lot of raised hands. And guess what? You're absolutely right, spot on. what we found in this cohort is that the association between wealth and dementia was actually stronger for those born in later years, age cohort 2, with, as you can see here, with an increased risk 2.74 for dementia compared to those born earlier, which was just 2.35. This work is published in JAMA Psychiatry and was a surprise for me to see that we didn't really manage to reduce socioeconomic inequalities over time in this country. Okay, so furthermore, we wanted to know what else matters behind the socioeconomic position one might have, how many financial resources one might have, what else can we look into to protect dementia, to protect us from dementia. So we start looking into the role of cognitive reserve with one PhD student funded from the Alzheimer's Society. For those of you who are not very familiar with cognitive reserve, this represents all the knowledge as accumulated by individuals through their life, through their experience, to increase their resilience against neuronal damage, to create a buffer, to withhold the neuronal damage which happens over the years as we age. This work has been published in British Journal of Psychiatry, and what he has done has looked at different various markers of cognitive reserve. One, it's very clearly established as higher level of education. Another contributor is the level of occupation, what type of work people do, which also it's really related to how we maintain and stimulate our brain, and also includes a lot of lifestyle and leisure type of activity. So pretty much what we do in our free time. And in terms of the range of leisure activity, we look here at the level of reading, how social engaged participants were, the journeys taken for simple holiday, fixed activity, even as pet care, gardening. All of these activities were captured as lifestyle behaviors. So what we found was that cognitive reserve index was associated with a lower dementia risk with about 35% lower chance. Okay, one might think perhaps this cognitive reserve is pretty much driven by the role of education and occupation, but then we took apart all these components and we found out that also leisure activities in itself are an important determinant and significant factor associated with lower dementia risk, which was really important to find. So to conclude, the current findings highlight that lifestyle factors, obesity, and socioeconomic position are important determinants of dementia risk in later life. And adopting a healthier lifestyle has been shown to curb dementia risk. Last but not least, leisure activity play a critical role. So how we spend our free time in mid and later life is extremely important for dementia prevention. Although we can never draw causal conclusion from any observational study, some of these findings suggest that maintaining optimal body weight, an active mental and social life in middle and later life might be beneficial. And the work presented here might provide some comfort to some of us that we might have a bit more power over our genes and how to control our own environment with important implication for our subsequent health. Some of these works have received some media attention. So if you want to listen more, there are BBC programs such as Inside Health, The Learning Revolution, which have covered some of this work, and also Daily Mail and Telegraph. The work presented here was conducted in collaboration with many colleagues and students from UCL, for which I have to address a big thank. And that's them listed here, and Professor Carol Brain from University of Cambridge. This is where I spent my last 10 years of work at UCL before I joined the SMS and Professor Nagy team. And this work is really dedicated to my amazing dad, whom I fortunately lost to dementia 7 years ago. Thank you for your attention, and please don't hesitate to contact me if you have any questions.